Basically, what I'm going to do over the next kind of 40 minutes is to talk about the background of goiters, the concept, how we should evaluate this, the surgical approaches and the techniques that we have, some of the outcomes that they were obviously in my PhD, and then provide a summary about what we should do. So, just as a general aspect, so multinodular goiters are very common. They can cause compression symptoms, and they quite a lot of them do require surgery. The intrathoracic growth is actually multifactorial, but we think that the negative pressure of the chest basically allows the kind of downward growth. About 90% of these goiters can be approached by a transcervical approach, and around about kind of 10% will require what we call an extracervical approach. And that's actually something that has been, really well, documented in the literature. Obviously, here at Guy's Hospital, being a tertiary center for this, these figures may be slightly different and skews. So the concept, what is an intrathoracic goiter? There has been a lot of narrative or different narrative about this. Some people call them intrathoracic, some people call them subclavicular, others retrosternal, others suprasternal, and others mediastinal. And depending on whether the country that you are actually in it, that they will call it one thing or the other. But probably clinically and radiologically speaking, the concept of intrathoracic goiter is probably the best thing that we have to call this type of pathology, although it is not necessarily one that a lot of people kind of strictly use. So there's been a lot of definitions over years. Any extension below the thoracic inlet in a surgical position, the thoracic gland reaching the aortic arch, the thoracic gland reaching the level of the T4 vertebra. But really, at the end of the day, the kind of the most accepted concept, which is basically started in the 80s with the Susan Smith and then Cadlick, is that basically those glands that at least 50% of the thyroid gland is below the thoracic inlet. So you can see here different examples of this. You can see this is a typical, retrosternal goiter. We can see the kind of different size of shapes. So there's as a spectrum of conditions. So what is the clinical presentation? Normally, the typical patient is somebody who's actually a female between the 5th and 6th decades, and the kind of the female ratio, male ratio is about 3 to 1. Some of the time, about a third of these patients may not have anything palpable, and quite a lot of the time they may present to A&E with shortness of breath, and then a chest X-ray is done, and you can actually see there is actually something in the mediastinum, but in fact there is nothing to feel in the neck. So about 10% of these are, as I said, discovered as an incidental finding. The majority of them will continue to grow over time, and then they will eventually cause compression symptoms. And some of them, as this poor lady here, may present as an acute airway emergency, and then some of them may need to have a very difficult tracheostomy. So how do we actually evaluate these goiters? So as a pre-operative evaluation, we need to make sure that we do have a full ENT examination. We'll always perform a fiber optic laryngoscopy that will provide a dynamic view, will allow us to see if there's actually any airway distortion, will assess the vocal cord movement, and it has gradually become an essential medical legal investigation, especially on patients who have had previous thyroid surgery, or they may have airway problems at presentation. Then you will do obviously a thyroid function test and thyroid antibodies, and then these different units will have other tests. We normally here we will use especially if we're thinking that we're doing a total thyroidectomy, then we'll do, for instance, a bone profile. We will do an ultrasound-guided fine needle aspiration for all of them, and then we will use obviously the current ultrasound classification of the British Thyroid Association, and we'll encourage the radiologists to make sure that they do use the U classification. In terms of kind of surgical planning, what are we going to do is we're going to use a multiplanar CT scan, and you can see here that this will give us a very good three-dimensional view. We will use contrast, except when there is actually allergy to iodine contrast, but this will really will give us not only a very good definition of the anatomy, but it will be a very good predictor of which approach we need to use for these patients. The British Association of Endocrine and Thyroid Surgeons and Huins, which is actually an otologist, designed this classification. He at the time was doing a PhD with Neil Tolley in North London, and basically this has been adopted as the main classification of intrathoracic goitres. And so when you go into the BIDES database, when they ask you to classify whether these goitres are at which level are, then this has been classified as a retroclavicular, above the aortic arch, and below the aortic arch, and they'll have basically a way we can then compare these goitres. In terms of the cytological evaluation, obviously we'll use the current PTA system, 1 to 5, and then obviously in Europe and other parts of the world, they will use the Bethesda classification. What we found in my PhD is that the pre-operative cytological analysis had the majority of these were Thy2s, either benign, but the number of them, and that they will actually be indeterminate, and some of them they will be malignant. So not is something that we just need to kind of really bear in mind, because sometimes there may be some discordance between what we find in the ultrasound findings and also what we find in the cytology. So my view, in order to plan the surgery properly, is that you should really do always a combination of ultrasound guided FNA, despite even if the ultrasound may give you just a benign reading. So what is the rate of malignancy? Interestingly, we found that the average kind of rate of potential malignancy was about 8%, and the occult rate of malignancy was about 5%. So even if you have those goitres that you have a preoperative ultrasound FNA that shows that this is actually benign, in fact that about 5% may be malignant, and I think it is actually very important for the patients to to know that up front. So this is a little more detail about the rate of malignancy and how specific and sensitivity it is our ultrasound guided fine needle aspiration cytology. But the most important thing is that we will need to do an ultrasound guided FNA, and also to understand that there's always going to be a retrospective rate of occult malignancy. The approach to these goitres needs to be multidisciplinary. It is no question that quite a lot of the complexities needs to be addressed as a part of a team that needs to be dedicated, experienced, and have all the tools like Cheng Ong, who some of you know, doing a fiber optic nasendoscopy intubation in this patient with a very large goiter. So we need the anesthesia, we need a dedicated thoracic team that they can do then the sternotomies, and then we need to obviously have a full setting of endocrinologists and nuclear physicians and specialist nurses. In terms of how we then approach this, what we found in my PhD is that the shape and extent are very good predictors of how we're going to need to approach these goiters. So, and what we find is that there were mainly kind of three main shapes: what we call the iceberg shape, the oval shape, and the tubular shape. So these oval and tubular shapes, as you can see, we'll be able to kind of get hold of the goiter in the cervical region and be able to track them. Whereas the iceberg ones, because of the conflict of interest, are going to be very difficult to deliver through the neck. The extent is also very important. So we found that a number of them were retroclavicular. A lot of them, they're just reaching the aortic arch, and some of them they were went beyond the aortic arch. So this group of just above the aortic arch will be quite easy to remove through a transcervical approach. Whereas if you go below the aortic arch, that's going to be much more difficult. So this is a very important slide of my PhD, in which we found that of the majority, as I said, there were transcervical approaches, 87%, and about 12% required an extra cervical approach. And we found that the risk factors for an extra cervical approach were the extent, as in per the Bites classification, the shape, which is something that we kind of, in a way, kind of invented or created, and that's kind of, it was my concept. And then the reoperation. So if you do have somebody who needs revision surgery, there's no doubt that very likely that they're going to need an extra cervical approach. And so based on this, we then can classify them into low risk, moderate risk, and high risk. So what represent each individual risks? Low risk will be those retroclavicular goiters. There will be no extension or beyond the aortic arch. The mediastinal component will be equal or smaller than the cervical component. So that means that we can actually exert be able to pull them out, and they don't have any previous surgery. And this is basically a classical example of this. Very big cervical component, very small intrathoracic component, and you can deliver that through the neck. The moderate risk of extracervical approach, these are people in which you will probably have to warn your thoracic team that these patients are coming to theater. So these are patients who will have significant mediastinal extension up to or beyond the aortic arch. There is no or minimal extension to the posterior mediastinum. There is a solid component between the cervical and mediastinal components, so you can exert traction. The mediastinal component is equal or smaller, and you can again basically pull them through. But then you'll think, well, you know, that's going to be perhaps a little bit difficult. You may have a potential problem with the vessels, and therefore a thoracic surgeon needs to be on site on standby. And this is a clinical example, a classical example. So you got this tubular shape. It goes beyond the aortic arch, but this patient, you can see this patient, you can actually remove that through a transcervical approach without any problems. And then we got basically a number of patients which will represent a high group for extra cervical approach, i.e. you will need to do a sternotomy or use another kind of way of dealing with it. So these are goiters that they are below the aortic arch, that they're recurrent, and they have this iceberg or inverted cone shape. Some of them may have giant extension. They may have kind of multiple components. Some of them, they're actually primary goiters. The goiters may have kind of separate components. The goiters may extend to the posterior pleura, and then it's very difficult then to access them through a transcervical approach. Primary goiters, as I said, so these are the goiters that they are primarily as completely separate in the mediastinum, and then of course the malignancy. Although my PhD did not specifically address the mediastinal malignancy. So this is basically a typical example of a giant goiter. So this is actually somebody who the goiter was extending down to the carina. There's absolutely no way you can actually be able to get that through the neck. This is another example of those goiters. They may have complex anatomy. You can actually see here that the goiters in the anterior and the posterior mediastinum, because this patient's sort of kind of goiter was basically riding on the innominate vessels, and it's very, very difficult for them to get up through the mediastinum, through the thoracic inlet. Then there'll be some patients in which there's no connection. So you can see that for instance here, there's no connection between the components of the goiter, and therefore you cannot really dissect them and exert traction. And of course the primary goiters. The kind of the fourth kind of type would be those patients who do have retrosternal, retrotracheal, or retroesophageal extension, and then sometimes actually very difficult really to get them through the neck, because you don't have enough ability to be able to maneuver the actual goiter. And of course the revision surgery, as we said before. And then the other kind of group is this iceberg or inverted cone, and that's because you cannot really just take them through the thoracic inlet, which is obviously much more smaller. And sometimes quite all these goiters, they may not be compressible. They get a lot of calcification because they bled into it, or because they've been there for many years. One thing is actually very important for addressing this is that you have a very good protocol of different aspects, and the two most important ones are the antibiotic prophylaxis, especially if you didn't need to do an sternotomy, and that's because you don't want the sternotomy to get infected, and that which will basically represent a catastrophic problem. The other thing that is actually very important, especially if you do total thyroidectomies, is that you make sure you do have a very good hypocalcemia protocol, and then we do have that in the intranet for you. Now then, probably the most interesting thing would be obviously how we approach them. So we will need to kind of make sure that we have all the surgical aids, we have the nerve stimulator, we have surgical loops, we have micro instruments. And then we, hold on, it's gone. Yes, and then power instruments such as the harmonica scalpel. So how we do the cervical approach? So basically what we do is we obviously have a generous incision. We do then elevate the subplatysmal flaps. We identify the strap muscles. We often need to divide them. It is important that we do have plenty of space to be able to dissect and control the structures of these big goiters. Then the first thing we do is to address the superior vascular pedicle and the superior thyroid pole, and that will allow us to mobilize the kind of the easy part of the goiter and allow that cranial traction that it will be so important to be able to get them through the neck. We will ligate all those vessels individually, and that, with the purpose of that, will be to reduce the risk of hemorrhage, to reduce the risk of the superior laryngeal nerve injury, and to, in terms of cancer, to reduce the risk of leaving a remnant. The next thing would be to go down, use a broad approach, identify the great vessels, like in this case, and you can see here, for instance, that the internal jugular vein is completely attached. You can see here the mid-thyroid veins that's completely stretched. So if you if you're not careful with your dissection here, you obviously can cause significant hemorrhage. You can obviously then sling the vessels appropriately, and then because of the size of these goiters, often you will need to ligate and divide multiple mid-thyroid veins. Now then, the most important thing is obviously the recurrent laryngeal nerve. The recurrent laryngeal nerve can be approached in kind of mainly three different ways. I think it is important that, especially in big goiters where we need to kind of dissect in a kind of a causal way, you could potentially have to identify the nerve at the cricothyroid joint, and then very gently peel them down, and that will allow basically a mobilization of that goiter without having to to cause a lot of congestion. We use that. This is a technique that I always kind of mention to Charlotte, because this was described by a French surgeon, Charles Prat in Lille, and it is actually extremely helpful in order to be able to identify the nerve and then not have any problems with it. The other kind of conventional approach is obviously to find the nerve in the lateral way. You've got to be careful, because as you mobilize the nerve can be completely attached to the posterior aspect of the lobe, and about 20% of them, they may be riding on it. So you need to make sure that your dissection is controlled and atraumatic. Then obviously that's fine for the cervical approach, but what we do if we do need to kind of do a combined cervical, a midline sternotomy approach, or nowadays what we do is a mini sternotomy approach. So we'll do the same. Essentially, we'll obviously do incision. The incision will be in a form of T. We raise the flaps, and then what we do is we'll have three components: the cervical dissection, the thoracic dissection, and the thoracic inlet dissection. So we do first the cervical dissection, as I described earlier. Then we go at the bottom. So we do the mediastinal dissection, and after we do that with the thoracic colleagues, and we identify and control the mediastinal structures, all the nominate vessels, the aorta, the pericardium, and the pleura. And then the thoracics are extremely concerned about the phrenic nerves for obvious reasons. And then when we've done that, that means that we have the goiter is actually mobile at the level of the thorax and at the level of the neck. And then we will then move to dissect the nerve and do the thoracic inlet dissection. And this is the third step. As I said, often the nerve is in the posterior aspect, and we'll be able to to mobilize it and then follow up superiorly. We've got to be aware of some of these posterior goiters, because as you can see here, the nerve is what I call kind of riding and diving. So it kind of it goes over the posterior component and then dives in between the two components of the goiter. Often happens that this big component, intrathoracic component, is actually coming from the tubercle of cervical. So the nerve is going to be right in the middle of it. So you've got to be very careful, because that's a really potential kind of site of injury. And then obviously we need to kind of look for the parathyroid glands. The superior parathyroid gland is often not a problem, but the inferior parathyroid gland, because the goiter is completely stretched, it will be sometimes very difficult to preserve. And so you need to stick to the capsule and then check the specimen at the end of the procedure to make sure that you don't take your parathyroid glands unexpectedly. And then finally, the Barrett's ligament, that, as you know, this is the part of the goiter, or the thyroid, is actually attached to the trachea. You've got to do that very carefully. We normally use bipolar a knife, and then you've got to be careful of the kind of the goiter weight. Sometimes you have kind of big goiters. We're taking sometimes kilos of goiter from the chest, and so therefore we need to kind of really control that traction. If you put a lot of traction, sometimes you can potentially kind of injure the nerve. So it is important that you do control that traction. And you can see here at the bottom how big that goiter is. So you've got to really handle things with lots of care. And then finally, we check the recurrent laryngeal nerve. We use nerve monitor. Obviously, we get a kind of an EMG trace. We wash. We do hemostasis. Sometimes Valsalva is required to do it several times. Sometimes, if we do have opened the chest, we need to kind of put dual drains, either one in the pleura and another one in the mediastinum. And as I said, it is important, not so much now, but in the past, obviously, we had a lot of problems with MRSA, and especially with the sternum. You need to make sure you do have appropriate MRSA prophylaxis. Now then, sometimes the extracervical approach is not going to be a midline sternotomy. There'll be goitres that may require a different type of approach, and you can see here why. Okay, because this is actually completely posterior. This goes to the posterior chest wall, and then so even if you use kind of the approach from the front, you will never be able to dissect that from the pleura. So they are mainly right-sided goitres. The majority are going to be in the posterior mediastinum, and they, as I said, they reach the posterior pleura. So you need to kind of use a different type of approach, and this is an example of that. So what we normally do is that we do a cervical approach. We do dissect the nerve, control the nerve. What we do is we put some Surgicel fibrillar between the nerve and the kind of the pleura, and then we dissect as much as we can into the chest, through here and through here. I said we just protect the nerve, and then when we approach, we do a lateral thoracotomy. In this case, a right thoracotomy, and then we find the nerve, and then when we see the Surgicel, that means that the nerve is immediately above, and then we can then dissect the goiter. Obviously, there's a lot of kind of structures. The approach is completely different. Sometimes you will see the superior vena cava, and then obviously the thoracic colleagues are very good at approaching this. So obviously the one of the things that potentially kind of wanted to correlate is that the more the weight or the more the heavy the goiter is, the more potential kind of blood loss will be. And we found that usually for these big goiters, you normally kind of use a mil of blood per gram of weight. So normally you just say if you have 100 grams of goiter, then normally your kind of blood loss is going to be potentially about 100 mils. If it's half a kilo, then we're up to 500 mils. However, with the current powered tools, obviously that's less, and it's very rare that we use that we lose a lot of blood. One thing that we found is that in terms of kind of the outcome of the recurrent laryngeal nerve is that there are some things that there will be a potential kind of risk. And of course, if you use an extracervical approach, if you kind of the shape of an iceberg, if you reoperate, if you do have an airway obstruction up front, if you do have a lot of blood, all these are going to be risk factors for recurrent laryngeal nerve injury. However, the risk of injury in general, if you do things properly, they are not going to be that big. There's going to be a permanent rate, which is probably bigger than obviously a small thyroid, which should be less than 1%. And but you will have a number of this that because of the sheer volume of the goiter, and because of the manipulation, the nerve gets tracked, and then you will have a temporary rate of recurrent laryngeal nerve palsy. Okay, but if you do use a nerve monitor, the risk of temporary palsy is not going to kind of you're not going to be able to kind of do anything about it, but you will definitely lower the risk of permanent palsy. You can see here, for instance, this goiter, we've just dissected that from the chest. We've done a sternotomy here, and then you can see that the nerve, just look at the shape of this nerve. So basically it gets tracked into those fibers of the goiter. So you can see really that it's very, very easy for that to injure. If you're not careful, if you know that this shape's can occur, then that can be a really big problem. But if you use neuromonitoring, there's definitely a less risk of permanent palsy. The hypocalcaemia, obviously, it's another thing that it's inevitable. If you do a total thyroidectomy, the risk of hypocalcemia in this goitres is about 6%. The majority with careful dissection will not have permanent hypocalcemia. There's also something that is very important to note, is that some of this patient could potentially kind of require tracheostomy, either up front or because there may be a kind of a significant problem with the nerve, or you've done a sternotomy and you don't want to, you have to kind of basically push forward to the side, for instance. Quite a lot of the time, we tend to not to or avoid a total thyroidectomy in the first place, and then sometimes we can do things on stages. Some of the patients, however, especially elderly patients with big, long-standing goitres, could potentially have some risk of tracheomalacia. The majority of them can be addressed by just putting some CPAP after the surgery, but it's actually something that you need to be aware of. And you can actually check that when you finish the operation, especially because the trachea becomes very, very soft. And then one just final thing to say is that interestingly, even from my kind of that group of for patients in my PhD cohort, the kind of the average length of a stay for these patients, for those who only have a transcervical approach, is about 3 days, and for those who need a sternotomy now is about 6 days. So it's not a really huge burden for these patients in terms of length of a stay. So just as a summary, just to say that these surgeries are challenging, that they require a very thorough preoperative evaluation, mainly with CT scan, with multi-planar views. That it's important that you do have a kind of a multidisciplinary approach, especially from the surgical side, to have a very good collaboration with the thoracic colleagues. That the complications really at the end of the day are comparable with a non-complex thyroid surgery, and the outcomes are really excellent, especially if you do have a dedicated surgical group. There's of course a lot of kind of potential work to be done, and what I have to say is that since I did my PhD in 2017. This is basically what I've been presented over the years, but over the past 5 years, we developed a much more kind of minimalistic approach. With all these patients were done with full sternotomies. Nowadays, it's better that we do need a full sternotomy. Quite a lot of these patients they do only require a mini sternotomy, and so therefore, in terms of kind of recovery and length of a stay and potential complications, is much better. So there's still a lot of work to be done. So thank you very much for your attention.